Good afternoon, everyone. My name is Kathy Ottenhoff, and I'm one of the Born coordinators. On behalf of Born Ontario, I'd like to welcome you to our provincial rounds, Pregnancy and Intimate Partner Violence with Review of Woman Abuse, data element collected in the Born Information System, or BIS. A question and answer period will occur at the end of our presentation. Please type your question into the chat box in the lower left-hand corner of your screen, and feel free to enter a question at any time during the presentation. As you have heard, these rounds are being recorded and they'll be posted to the Born Ontario website. Today, we're very pleased to have Donna Joyce presenting. Donna is a graduate of Waterloo University and has committed her 34-year career to supporting vulnerable populations. She is currently the manager for the Kingston General Hospital Sexual Assault Domestic Violence Program, the chairperson of the Kingston Frontenac Anti-Violence Coordinating Committee, and past co-chairperson for the Sexual Assault Domestic Violence Treatment Center Provincial Association. So before I turn it over to Donna, I'd like to review with you some of the Born data elements on women abuse. So we'll have a look at the Born Information's data definition of woman abuse. We'll look at the data review for 2012-2013. We'll have a look at data quality, and we'll have a look at improving data capture. So the BIS data element definition of woman abuse is a self-disclosed threat of or actual physical, sexual, psychological, or emotional or financial abuse. The pick list definitions found in the BIS include no disclosure, asked but no abuse was disclosed, or asked and the response was no. Disclosure and unable to ask, which means not asked for any reason, and abuse was not documented in the patient's chart. This is a screenshot of a labor encounter found in the BIS, and we can see on the History tab, there's the data element of woman abuse, and it's circled in red. Woman abuse data definition can also, a database element can also be found not only in the labor encounter, but in the antenatal specialty encounter, the antenatal general encounter, and birth mother encounters. In 2012, Born took the advice of experts in the field and added this important data element into the BIS. While this is a new BIS data element, collecting this information is not new to clinical practice, but for many reasons, collecting the information well has historically been an issue. We know based on the literature, in all likelihood, woman abuse in the BIS is underreported. However, there's still very important information to review. So this is a data review, April 1st, 2012 to March 31st, 2013. I'd just like to thank Dan Bedard at Born for pulling these numbers for us today. And you can see on the left-hand side of the screen in the little orange box, during this time period, there was a total number of pregnancies recorded as 141,486. The database element picks are found on the left. So no disclosure was chosen 71.3% of the time. Disclosure, 1.8%. Unable to ask, 26.9%. And missing data at 0.08%. And the missing data, I believe, comes from the fact that at one point we did have an unknown data pick, and that no longer exists. So if you exclude unable to ask and missing data from the denominator, it reveals a true disclosure rate of 2.5%. So we can look at this data in another way and say, of the women that were asked and answered the question of woman abuse, 2.5% disclosed. And we'll talk a little bit more about what those numbers mean in a minute. So what can affect the quality of this data? Well, abuse in general is often hidden, making accurate statistics difficult. It may be lack of training and education for healthcare professionals on how to ask the question properly to screen for women abuse. To be most effective, the questions need to be conducted in a private setting, and asking the question without family members present may require asking for time alone with the woman. And as many know that are on the call, having worked in labor and delivery or in the maternal child setting, that family members are very close, especially during that time. Understanding the definition of no disclosure, asked, but no abuse disclosed, or asked and the response was no. So the important word there is that the patient was asked. And was she asked in private? And the other important piece to note here is no disclosure in the BIS should not be chosen only if the patient doesn't volunteer the information. She needs to be asked. So improving data collection. So sites can review their own data on women abuse from the BIS by downloading the data download reports, which are found in reporting. And if any of the sites need help with that, they can ask their board coordinator for help. So once you have a look at the percentages, once you download your data, review the percentages for each pick list. Do the percentages make sense to you? Do you suspect underreporting at the site? And if you do suspect underreporting, why? Do the staff need more training and education on women abuse and how to ask the question properly so women feel safe? Do your staff understand what to do when a patient discloses? And do staff need training on the definition, the BIS definition of what no disclosure means? Needing to ask. So why should we collect this data at all? Well, women abuse is an important health issue. And women who suffer abuse in pregnancy are more likely to have adverse pregnancy outcomes, including antepartum hemorrhage, IUGR, preterm birth, and perinatal death. Another important reason to collect this data is that with pregnancy, it brings a big opportunity. There's potential for intervention as the woman has more contact with her healthcare professional. Born data can be used to develop policies, programs, initiatives, and research to improve care of women and children living in an abusive relationship. So just going back to the statistics that we looked at for the 12-13 fiscal year, we noted that over 38,000 women were not asked about women abuse. So if we apply our 2.5% disclosure rate from the BIS, which is likely underreported, but if we apply what we have, the 2.5 disclosure rate of these women, if 2.5% of the 38,000 women had disclosed abuse, 951 more women could have received help. So that's a pretty eye-opening statistic there. So by improving capture of this data element in the BIS, we can improve and facilitate care for these women. And improving and facilitating care is the reason BORN exists as a registry and the reason organizations work so hard to enter accurate and complete data. So I'm going to turn it over now to Donna so we can learn more about pregnancy and intimate partner violence and how to screen women for abuse. So I'll turn it over to you now, Donna.
Thanks, Kathy, and I appreciate the invitation to speak to your group today. You have asked me to outline our work with the Sexual Assault Domestic Violence Program, specifically in relation to intimate partner violence and pregnancy and related screening practices. At Kingston General Hospital, we've been providing and responsible for a comprehensive range of services and supports for victims of violence, those who have experienced both a sexual assault and/or domestic violence assault. And our specific area includes the Frontenac and Lennox and Addington counties. There is a continuum of care in the community for victims of violence, but your sexual assault domestic violence program is but the first stop on that continuum. for a couple of reasons. Predominantly, from a health perspective, we play a very large role in ensuring the health of the victim, but we also play a significant evidentiary role. Additionally, we offer education, support, risk assessment, safety planning, and follow-up. But it is important to note that we do all of our work in coordination with our community partners. As adults, we tend to typically think of penetration as the definition for sexual assault. But the reality is that according to the criminal code, sexual assault is defined as the violation of one's sexual integrity. It is a broad and comprehensive definition. And intimate partner violence is defined as the use of physical or sexual force, actual or threatened, in an intimate relationship. Those intimate relationships can include current boyfriend, ex-boyfriend, current husband, ex-husband, current same-sex partner, ex-same-sex partner. You need not live together and or have sex in order for the definition to apply. The other important component is the threatened component, and by that I mean if an individual is experiencing stalking and or harassing behavior, it's important to acknowledge and recognize that the threat in and of itself is more than legitimate in terms of intimate partner violence. So when I'm presenting to Queen's University, I'll often use the example of a couple who begin dating in October. She finds his behavior restrictive and threatening. She then breaks the relationship off in February. He's not happy with that decision. He begins to harass and stalk her and then assaults her. The criminal code considers that an intimate partner violent act, even though they are no longer dating, perhaps they never had sex, and they're not living together. Intimate partner violence is cyclical in nature. It begins with the building of tension. You have the episode itself, and then what is commonly known as the honeymoon phase, a period of remorse and apologies, gifts, flowers, and romance. But the abuse will continue and will increase in severity and frequency until there is no longer a honeymoon phase. It's important to acknowledge that intimate partner violence is a gender issue. Intimate partner violence, for the most part, refers to male violence against women, and violence which is used to gain power and control through isolation, fear, entrapment, and compliance. Intimate partner violence is not an anger management issue. And while the bruises and lacerations will generate attention and disgust, it is important to recognize and acknowledge other forms of intimate partner violence, such as emotional abuse, social abuse, psychological abuse, which can be just as damaging and just as scarring. There are well-known and established red flags for intimate partner violence that you see here. But certainly pregnancy is known as a red flag for increased violence. Abuse will often start and or get worse during pregnancy. The assailant may begin to feel a sense of loss of power and control. He may be experiencing competition for her attention. Of course, it is at this time where she has baby showers to attend, doctor's appointments to ensure that she gets to. There could indeed be a dislike for any physical and emotional changes that she may be going through. Assaults may indeed escalate during this period. The assailant may control, limit, delay, and or deny access to prenatal care. But she herself may choose not to attend her regular doctor appointments due to the visible injuries. The 1993 Canadian Violence Against Women survey found that 21% of women abused by their marital partners were assaulted during pregnancy, and that 40% of the women who were abused during pregnancy reported that the abuse began when they were pregnant, and that almost two-thirds of abused women reported that the abuse escalated during pregnancy. The vast majority of my provincial colleagues have initiated some form of screening question for both the emergency department and the inpatient assessment form. The sample on your screen outlines what our Kingston General Hospital Emergency Department asks on our triage form. Are these injuries the result of someone hurting you? Is the question that is asked. Then the triage nurse is asked to identify whether or not SEDV was offered and or contacted. It has been proven that women don't mind being asked the question if they see that it comes from a place of sincerity and belief. I encourage you to ask the woman before, during, and after pregnancy. And for me, it is simply not good enough to include a screening question without properly training those who will be asking the question. I often ask the emergency department nurses to choose the wording and the phrasing that is comfortable for them. The victims will certainly notice any sense of discomfort on your part. How the questions are asked are as important as the words themselves. You need to hear the disclosure, believe the disclosure, and validate the disclosure. In order for a disclosure to occur, make sure that she hears from you that it's not her fault, that she's not alone, and that there is no excuse for someone hurting you. Asking about abuse lets the victim know that she's believed and respected, certainly that she's not alone, that you're willing to hear about the topic, that you've certainly experienced other disclosures, that you're taking her report seriously, and that she can get help by the mere fact that you know where to turn. We've been able, as an SEDV program, over the last 11 years, to remove the anxiety and the apprehension from an emergency department, from pediatricians and gynecologists, physicians and nurses alike, by ensuring a skilled and competent forensic nursing team who are trained to do this work, and just as importantly, who want to do this work. Our hospital colleagues have been very clear with us that it makes a significant difference in their willingness to hear the disclosure when they know that we are available to arrive 24/7 to assume care for the victim. It is important to note that assailants will attempt to align themselves with the health professional. They may try to answer on behalf of the victim and may be unwilling to give her the privacy necessary. Do not ask a screening question in front of her partner, and or do not provide materials in order for her to take home with her. By doing so, you have just put her in extreme danger. This is an old and yet very useful document that I still include when training the SEDV members of our team. People often ask, why doesn't she just leave? But the reasons are numerous, but I have named only a few here for you today. She certainly may feel that it's her fault. She may consider it normal behavior. She's certainly afraid, maybe fearing for her life or the lives of her children if he has threatened to either hurt and or kill them. She's powerless, isolated, may not have any money of her own, experiencing family or religious pressure to stay. She's worried about losing the children. She really does hope for change. She wants the man that she married, and she wants the relationship that she's dreamed of. Because intimate partner violence is not an anger management issue, but rather an issue of power and control, it is imperative that you as the healthcare professional respect her wishes regarding any involvement with police and any timeline regarding her decision to leave the relationship. Leaving an abusive relationship takes time, money, excessive planning, and she needs to be able to plan with support services for a successful and safe departure. The Domestic Violence Death Review Committee report is an annual review of homicides at the hands of an intimate partner. Each year, the report gathers information on triggering behaviors, and consistently, year after year, the greatest risk of severe injury and/or death is when the victim has decided to leave the relationship or has just left. And why? Because it is the ultimate sense of loss of control. The victim is the best judge of her own safety, and their decision must be respected. To contact police without her consent and have the police arrive at her door has just put her into extreme danger. I want to point out that at this Kingston General Hospital, we are but one of 35 sexual assault domestic violence treatment centers across the province. All of us providing very similar work. You might notice some minor variations, but philosophically and operationally, we're all pretty much the same. What I most enjoy about the Ontario network is the access that we have for our victims to obtain the same level of care regardless of where they may want the service. For example, if we're supporting a young 22-year-old pregnant woman who has presented to see us in our treatment room, and she is now deciding to leave her abusive relationship and return home to her parents, who may live in Sioux Lookout, Cornwall, Windsor, Toronto, I'm in a position upon her consent to forward her care to one of my colleagues who will pick up where we were leaving off. She'll be able to solicit social work and nursing care at that new site with her parents. I've included the SADV Treatment Center website for your review so that you can take a look and look up your SADV program close to you. When the victim confides in you and discloses that she has been assaulted within the last 7 days, I would ask you to use this as an opportunity to say something like, are you aware of the sexual assault domestic violence program? Can I tell you a bit about the services they have to offer? And may I call them for you? Our SCDV program at Kingston General Hospital will respond in a timely and specialized manner. And we will respond either to our emergency department or to an inpatient floor. Our eligibility criteria is an adult, 16 years of age and over, a sexual assault and/or an intimate partner violence assault within 7 days. At our site, you simply contact switchboard and ask to see the SEDV nurse on call. Our specialized nurse will respond within 30 to 45 minutes. No longer do victims of violence need to compete for services alongside car accidents and heart attacks in the emergency department. Our nurse will receive the victim in the emergency department or the inpatient floor and take them to a confidential, discreet, and exclusive treatment area, a room for our use only, where it is one-on-one, where there is absolutely no rush. We will test and treat for sexually transmitted infections, pregnancy, and HIV. We will collect and document forensic evidence in the form of the sexual assault evidence kit, forensic photography, and body mapping. In fact, in our particular area, the police actually defer forensic photography to our attention. It makes sense that, in fact, victims of violence would be much more comfortable in showing us their bruises and lacerations and abrasions in the quiet room, in the confidential room of our treatment area versus a police station. We will body map each and every injury, accompany that with a photograph and our documentation. The Crown attorneys have been very clear with us that we've been making a big difference in court for quite some time. It's very difficult to dispute that kind of evidence gathered at the moment of crisis. We offer a physical assessment, full head-to-toe assessment, safety planning, and each victim actually receives a toiletry bag if they are so choosing to seek safe shelter and not return home. We have a toiletry bag that consists of a washcloth, toothpaste, toothbrush that have been generously donated to us by our finance department. And each and every victim receives a teddy bear. You might wonder why, but you need only to see the reaction once to understand. Our SCDV program and all of our nurses make every effort, every attempt to restore the dignity and the sense of personal power that has been stolen from the victims. I do want to mention the availability of the RNAO nursing practice guidelines for screening. They would be most helpful in your particular department, and I hope that you have found the material helpful in your work. And I would strongly encourage you to contact your local sexual assault domestic violence program and ask for specific and enhanced training opportunities. Thank you very much.
Thank you, Donna. Just like to remind everyone, if you have any questions, please type them into the chat box. You can access the chat box on the bottom left-hand side of your screen. And just while we're waiting for a question, I just had one for you, Donna. Do you know the prevalence rate of woman abuse during pregnancy in the province or in Canada? Is there a general number? Because when we say that the prevalence rate in the biz might be underreported according to the literature, do you know what type of number we would expect to see?
I don't specifically for intimate partner violence, but when you consider the general numbers of 1 in 5 women indicating that they are a victim of either sexual assault or domestic violence, those are significant.
Wow, 1 in 5. And I have another question for you. So who offers the training at the hospital? So and you mentioned the 35 sites that have sexual assault domestic violence programs. So I would assume those programs would provide training to the sites if they asked for it. Do sexual assault domestic violence programs head out to other hospitals other than where they're based? Other smaller hospitals?
Yeah, it's a great question. We are responsible, as you know, for Frontenac and Lennox and Addington. So in our particular area, we're responsible for not only Kingston General, but Hotel Dieu and the Community Hospital in Napanee, the Lennox and Addington Hospital. And that also includes the Providence Continuing Care sites. So each particular SCDV program has an area in which they are responsible, and that could include 3 to 5 different hospital sites.
Okay. And if it was a smaller site not serviced by one of those programs, would social work be able to take that on training? Or is that a good...
I think that they would be able to, but I think that you would find that your SCDV program, every single hospital, would likely be covered to some degree by a sexual assault domestic violence program.
Perfect. Thank you. There's a question in the chat box. It says, just wondering about the 7-day limit in your eligibility criteria.
That is up for upcoming change, actually. It used to be, when I first started the program, victims of violence needed to present to us within a 72-hour frame. Because of the sensitivity of DNA evidence, and the Center for Forensic Science recommended that we extend our eligibility criteria to 7 days. Most recently, our particular provincial network has learned that limit may indeed be extended to 12 days. But in our particular area, we have not yet made that change. It only came to our attention last week. So all of that is based solely on the Center for Forensic Science recommending to the 35 provincial sites that we do so, and based on the opportunity to obtain a DNA evidence from our forensic collection.
Thank you. Another question here is from Hillary. Can you talk a bit about how you handle referrals to the Children's Aid Society? And then she says regarding safety to children at home.
Certainly. It becomes our responsibility, all of us. We have a legislative responsibility to make contact with the Children's Aid Society if, in fact, a person in a position of power, trust, authority, or supervision has impacted a child. So when we have a mother present, and she comes in tow with her small children, we work with her and actually make the contact to CAS. We have a legislative responsibility to do so. We share that responsibility with her, and we involve her in the call. We would never make a call to the CAS without involving the client. It's another way of ensuring and keeping her as safe as possible. You can well imagine that it would not be appropriate for her to go home and then the next day for a CAS worker to show up and then the assailant to find out that in fact she had solicited our services. So we work with the CAS if in fact we need to design a particular code in order for contact to be made with her in a safe manner. We'll do that. Again, we do it with her and not behind her back.
Thank you, Donna. There's no other questions in the chat box at the moment. Oh, here's something from Anne. A 2003 U.S. study found prevalence, sorry, it's jumping around a little bit, U.S. study found the prevalence of abuse across the 16 states to be 7.2% during the 12 months before pregnancy, 5.3% during pregnancy, and 8.7% around the time of pregnancy. And again, Donna, probably underreported, you think?
I do. I'm afraid I do, yes.
Yeah. And Donna, do you know where the numbers come from? Are they usually surveys? How do they come by those numbers? I'm just thinking Bourne has a real opportunity, to capture some accurate numbers on this if we can, ask every patient and ask it in the way it should be asked.
I think you certainly do have an opportunity to make a difference in the lives of the women that present to you. You really do. You may also want to consider linking with other provincial networks, such as the Ontario Women's Directorate, the Ontario Network of SCDV Treatment Centres. I think there would be terrific opportunity for some joint initiatives in this regard.
That's awesome. Thanks for that. I'll just leave our chat box open a little bit longer. I had another question, Donna. Intimate partner violence during pregnancy. Are negative health behaviors increased? So do these women try to self-medicate with alcohol, drug abuse, smoking, not going to prenatal care, those things? Do you see those negative health behaviors should certainly be a red flag in pregnancy, I would think, to screen for partner violence?
I think it's important to certainly screen for them, but when you give yourself an opportunity to ask the question, you're actually getting to the real core issue, which is the fact that she's not feeling safe at home. When I take a look and ask myself to review the women who have presented to see us, I would suggest to you that not a lot of them are self-medicating with alcohol and those kinds of things. They're actually seeking safety, but it certainly would be something to consider.
Thank you. Another question here, it says, do you see increased reporting if the women are able to answer a questionnaire on their own?
Well, I don't think it could hurt, but I think there's a terrific value in actually hearing from someone else that, in fact, it's okay to disclose that I believe you, that you don't deserve to be hurt. There's value in that response rather than collecting paper. I'm not certain. I guess on the one hand, I'm thinking that any opportunity to ask the question is helpful, but it's nice for her to know the response that she's going to get. It's why I spent a little bit of time on talking to you about training the people who will actually be asking the question. It's absolutely critical.
Thank you. Here's a comment or a question from Lauren. I'm a health researcher interested in the effects of intimate partner violence on women's reproductive health outcomes. Do you know if there are any longitudinal measures of women's experience with intimate partner violence and later health outcomes in Canada?
I'm not aware myself. No, sorry.
Okay.
Our Ontario network may be, though, and I can certainly leave with Kathy the name of our provincial coordinator. She may indeed know.
Perfect. Lauren, if you want to just pop me a little email, I'll follow up with Donna on that, and I'll send you some information. So I'm just going to tell you my email address now. So it's OTTENHOC@kgh.kari.net. And you can also find me by going to the Born Ontario website. Under the coordinators, all of our contact information is there. And I'll definitely follow up with Donna for you. Anne-Marie says, I noticed that there is no sites north of Sudbury North Bay. Where do prenatal clinics refer when they're in Northern Ontario, north of North Bay? Do you know that, Donna?
I do know that some of our sites actually provide service to the outer area, to the most northern area. But again, I can get that information to you if you can contact Kathy.
That's great. So Anne-Marie, just again on the Born Ontario website under coordinators, you'll find my contact information there. All great questions. I'll just leave that open for another minute. So while we're waiting to see if another question pops into the box, you can see our slide there advertising our Born conference. Born is hosting a 2-day conference, The Right Information in the Right Hands at the Right Time, using data to improve maternal child care and outcomes on February 6th and 7th, 2015 at the Fairmount Chateau Laurier in Ottawa. Registration is now open. Early bird deadline is Monday, December 15th, so register on or before December 15th to receive special pricing. The regular registration deadline is February the 5th, 2015. And you can find out more about our conference on our website at bornontarioconference.ca. So I'm just having a look again in our question box. I don't see anything new. There'll be no rounds in December, so our next scheduled rounds are January 15th, and we will be hearing from Wendy Catherine, the OMAMA project consultant. OMAMA is a maternity care communication project started by Born and sponsored by eHealth Ontario. The title of Wendy's presentation is OMAMA, an innovative consumer eHealth project for improved maternity care. So we're looking forward to that in the new year. And I don't see any more questions in the chat box. So I'll be able to give you a little bit of your afternoon back. But before we do that, I'd just like to thank Donna so much for a great, great presentation. Thank you for the review of woman abuse and intimate partner violence in pregnancy and helping us understand the importance and value of proper screening. And a reminder to our sites to review their data on woman abuse, because truly, honestly, with better knowledge comes better care. And we can start looking after these women a little bit better. So thank you again so much. Thank you to Donna, and thank you to everyone for your attention. Bye for now, and we look forward to having you back in January.